Okay, we are live.
Wonderful. Hello, and welcome to the Joint Committee on Children, Youth, and Families. This is our second interim meeting, and this is the meeting where we will be discussing long-term care topics. Hold on. Sorry. This is the meeting we'll be discussing long-term care. We're going to talk specifically about how COVID has impacted long-term care from government agencies and advocates who were there on the front lines and are still there. If you were on this committee last year, you will remember, and if you're new, you should know that we submitted policy recommendations to the General Assembly in this area last year. We submitted 5 recommendations specifically related to long-term care. 2 of those recommendations were taken up through legislation, including improving visitation and quality of life, as well as improved COVID case reporting and a dashboard reporting on vaccination rates at long-term care centers. So we were very happy to see that. We also recommended last year that the General Assembly support initiatives to expand and strengthen the long-term care workforce. We touched on this topic at our last meeting, and we're going to talk a little bit more about that, probably a lot more about that at this meeting today, because this is a workforce where the state is really struggling. We need to be creative. So we're seeing continued difficulties in recruitment and retention and the impact of the pandemic on this predominantly female workforce. And we heard at last month's meeting that women have left the workforce in greater numbers than men, and they've been much, much slower to return. So this is a challenge that we're facing. Just to put this in context, of course, Maryland's population is aging dramatically. In 2015, about 18% of Marylanders were 60 or over. By 2030, that number is going to be 25%. So again, 18% in 2015, 25% by 2030. And over the course of the pandemic, we've seen that older Americans have reported real serious financial strain. 19% of older Americans have reported using up all of their savings or losing their main source of income during the pandemic. It's almost 20%, so that's jarring. Of note, another recommendation we made last year was recommending an increase in funding for home and community-based services. In particular, we suggested that the state should adjust the balance that they use for long-term care services provided in the home and community as opposed to in nursing care. So that I know is a topic we will also be discussing today. So with that, I will welcome our first panel. And just so the members know, first we're going to be hearing from NCSL for an overview. We'll also be hearing from Leading Age Maryland, and then the Department of Health will be coming, and they're going to give us that Medicaid one-on-one that we discussed last month would be very helpful. And then we're hearing from the DDA, as well as, we're hearing from the Developmental Disabilities Council and from MAX as well as the DDA. So we'll be sort of pivoting to disabilities issues at the second half of the meeting. With that, let's hear from NCSL. We have Samantha Scotti and Emily Blanford, and members should have this presentation in their email. Thank you so much and welcome.
Thank you so much, Delegate Kelly, and thank you so much for inviting us here today. As Madam Chair mentioned, my name is Samantha Scotti, and I am a Senior Policy Specialist with the National Conference of State Legislatures. Next slide, please. So in case you're not familiar with NCSL, I believe this is the right slide deck. Okay, in case you're not familiar with our organization, we are your bipartisan membership organization serving all legislators and legislative staff across the U.S., and we are here to strengthen the legislative institution. Next slide. So we do this through a number of different functions, as you'll see here on the screen, and mainly through trainings, policy research, meetings, and, for example, through this presentation that we're providing you all today. Next slide. So we've been invited here to talk about long-term services and supports, and particularly in the context of the COVID-19 pandemic. And so we're going to start by providing a broad overview of long-term services and supports, and then also highlight some of the recent state activity, leveraging some of the federal flexibilities, particularly under the increased FMAP provided under ARPA, and then also briefly discuss some of the federal funding proposals. And of course, we will have time at the end for question and answer. So when I say long-term services and supports, I am referring to a range of health-related and social services provided to individuals with certain functional limitations. And these services can be provided in a number of settings. So in institutional settings like nursing homes or assisted living facilities, and also in home and community-based settings. And today we've been asked to primarily focus on home and community-based settings. So as you'll see here, Medicaid is the primary payer for long-term services and supports, paying for just over half of all LTSS, which equals about $197 billion each year. So clearly, as you're all very aware, Medicaid LTSS has very large implications for both state and federal budgets. Next slide. So Medicaid has historically relied on institutional settings to provide LTSS, but over the last 2 decades, federal and state policymakers have focused on shifting or rebalancing LTSS away from institutional settings and more towards home and community-based settings. And this is due to a number of reasons. One being personal preference. So individuals tend to stay in their homes or communities if possible, rather than going to institutions. Also, the relative cost effectiveness of home and community-based services over institutional care. And then more recently, the COVID-19 pandemic has also accelerated interest in home and community-based services as it allows this often vulnerable population to remain safe in their homes and avoid certain congregate care facilities, which we saw tended to be early hotspots during the pandemic. So you'll see here in the light blue, the percentage of LTSS spending going to institutional care, and dark blue, the percentage going to home and community-based services. So you'll see over the recent years here, the percentage of spending going to HCBS increasing and actually outpacing institutional care. Next slide. So Medicaid, the Medicaid program identifies both mandatory and optional services. Institutional care is a mandatory service and home and community-based services are actually optional. Now, every state does provide home and community-based services to their enrollees, but they do this through a number of different mechanisms because it's technically an optional service. And that is Medicaid waivers and Medicaid state plan amendments. And many states operate various Medicaid waivers and state plan amendments concurrently. So for example, some waivers might target specific groups like adults or seniors with dementia or adults with traumatic brain injury or children with developmental disabilities. So to the far right here, you'll see the number of states that operate or offer home and community-based services through 1915C, home and community-based service waivers, and 1115 demonstration waivers. And then on the left here, you'll see the number of states that provide these services through state plan amendments. Next slide. Now into the context of the pandemic. So as I mentioned earlier, and as you are all very aware, the pandemic has underscored the importance of delivering these services in homes and allowing folks to reduce exposure to the COVID-19 virus. So recognizing this, some states, particularly early on in the pandemic, pursued flexibility in delivering home and community-based services through an Appendix K waiver. And this is an Appendix K of an already approved 1915C waiver. So these waivers aim to increase flexibility in HCBS delivery and also ensure continuity of care for enrollees during the pandemic. So states pursued various actions through these Appendix K waivers, as you'll see here on the screen, like allowing providers to hire family caregivers as direct service workers, as you'll see in the Alaska example here, allowing for electronic service delivery through modes like telehealth, as you'll see in the New Mexico example, expanding settings for service delivery. For example, Washington expanded HCBS care settings to include hotels and churches, or increasing provider payment rates, like this Pennsylvania example you'll see here in the bottom left. So while these actions were taken during the pandemic, there is potential, and some states are considering making these flexibilities permanent beyond the public health emergency. Next slide. So the American Rescue Plan Act, ARPA, also recognized the importance and tried to increase flexibility within home and community-based services by providing an increased FMAP, the Federal Medicaid Assistance Percentage, for spending on Medicaid home and community-based services by 10% from April 2021 to March 2022. And as a reminder, FMAP reflects the federal government's share of the cost of covered services in the Medicaid program. So to take advantage of this increased FMAP, states must maintain their current spending levels on home and community-based service levels and use these funds to enhance activities that expand or strengthen Medicaid HCBS. I do know you will be hearing later today about how Maryland is planning to leverage this money and a little bit more about CMS requirements to utilize this. So I'm going to focus more on some state examples about how other states are leveraging this increased funding. So state plans were due to CMS just this past summer. So we're seeing states are in varying phases of implementation and approval of their plans. But the Kaiser Family Foundation did conduct a study that they released in early August that surveyed a handful of states that reported their early plans for the use of these new ARPA funds. So of these early plans, the most frequently reported activities were provider payment rate increases and workforce recruitment. So you'll see that here in 18 states and 13 states here on the left-hand side. Other common activities you see here are serving more HCBS waiver enrollees, developing worker training, and supporting family caregivers. There were a handful of other activities that states reported, and those were emergency equipment and supplies, providing worker hazard or overtime pay, providing services to mitigate enrollee isolation due to the pandemic, and funding nursing home to community transitions. Next slide. So federal funding proposals and long-term services and supports. So as you'll see, this slide is a bit vague, and I've intentionally left it vague just to reflect that these negotiations and discussions are quite fluid right now. So a little bit of context, as you likely remember, earlier this year, President Biden released a proposed plan that included investments in various sectors, including infrastructure, education, healthcare, housing, environment, among others. So the Senate has recently passed a $1 trillion infrastructure bill that included of the physical infrastructure funding. And there's a separate 3.5, or most recently, that's the most recent price tag, $3.5 trillion social spending package that is currently in limbo. You may have heard this referred to as the human infrastructure package. And it includes numerous things like healthcare, childcare, and education. So there are a handful of provisions in that current proposal that do relate to long-term services and supports or the population being served by these services. So I'll reference a couple of those. So one is an investment in the direct care workforce. So those are those workers that provide direct services to this population, personal care attendants, personal or home health aides, personal caregivers. You might hear them referred to as a number of different titles. Also, there's funding for an expand Medicare benefit that would expand Medicare to vision, dental, and hearing. There is also substantial money being proposed to expand home and community-based services. So this includes a permanent extension of the Money Follows the Person program. So that is a program that was created years ago, and a number of states have taken advantage, but is a time-limited program. And it aims to support individuals transitioning from institutions to home and community-based services. So there is proposed funding to expand or extend this program permanently. And then there is also a proposal, proposed funding for a permanent 7 percentage point increase to the FMAP if states implement an HCBS improvement program. So again, many of these proposals are increased funding, the funding levels, all this is quite fluid, and those funding levels and will continue to be a part of the negotiation as these bills continue through the process. So that the House has not voted on this physical infrastructure bill that I referred to either earlier, and there is a progressive group of representatives in the House that are trying to tie their support to that physical infrastructure bill to this human infrastructure bill. So again, lots of negotiations going on, and this bill is following the progression of these proposals quite closely and is happy to break them down further if it would be helpful. And these proposals are, of course, different from the continuing resolution that passed last week that continues to fund the government at current levels, and the vote that will need to take place to address the impending debt ceiling, which is coming up in mid-October. So again, happy to dive into some of those proposals, but we're hesitant to report on actual funding levels for those currently, just because those are likely to continue to kind of shift as folks negotiate. Next slide. So I do know that next slide, please. I do know that I went over a number of these topics very quickly, and kind of breeze through some of them. So happy to dive into greater detail if there are specific state examples that you'd like us to provide additional details on or break down even further. And my contact information is here on the screen, and also happy to take some questions now if there is time.
Thank you so much. And are we also hearing from Emily Blanford, or is it just you?
Yes, so I'm handling the presentation, but Emily and I are here for Q&A.
Perfect. So do we have any questions from the committee? I'm looking for any hands raised and I don't see any. I just had a brief question. So can you tell me more about the Home and Community-Based Services Improvement Plan? What does that mean? What are we looking for if that were to be federally funded permanently or in an increased way?
So for the improvement plan that's currently being proposed at the federal level? Yeah. Gotcha. So I could definitely provide you more details on that. So as we know now, basically, we have many explicit details about what those improvements would do. But it looks like there is, so it ties some of that percentage increase if states adopt models that promote self-direction or meet other requirements. So I can look for more information that kind of dives deeper into that, but as we know now, I think it would be around, there's some stipulations around self-direction, and also I think maybe some quality metrics for improvement, but happy to get some more information on that.
Awesome, thank you. And I'm seeing a question in the chat, and I think the question is about the money follows the person. The question is, can you provide more information on the returning citizens? So I'm thinking that's the money follows the person program.
Sure, yeah, so the money follows the person program is actually has been around for some time. I might have Emily expand on some of the details of that, but basically it provides extra support for individuals who are able to transition from a nursing home back to home and community-based settings. So that was a time-limited program that states needed to apply to CMS for approval, and this would just extend that permanently, that extra. It's I believe it's an extra FMAP. I'm not sure what percentage that would be. Emily, do you know? But it was additional funding to states to help support that transition.
Wonderful, thank you so much. I'm looking for any more questions. It doesn't look like we have any, so I will just say thank you so much. That was a great presentation and we really appreciate it. And let's move on to leading age. Allison Siborowski, I believe, is here today. Hi, Allison.
Hi, how are you?
Good, thanks. How are you?
Great. Thank you for having me here today. Thank you to our chairs and to members of the Joint Committee. My name is Allison Siborowski, and I am the President and CEO of Leading Age Maryland. And we are an association that represents not-for-profit aging services providers in the state of Maryland. So some of what I reference, you will have heard about in the presentation that came just before me. But what I'm going to cover today is a bit about how the pandemic has affected aging services providers in Maryland, a bit about funding for HCBS and some updates on what we know is happening, and then some policy recommendations. If you could go ahead to the next slide, that would be great. So Leading Age Maryland, who are we? We have about 135 members across the state. And we represent organizations from all different parts of the continuum. We have almost 90 affordable senior housing organizations that are members of ours. And so the individuals that are living there really are needing additional access to home and community-based services. And then we have many members who are life plan communities or CCRCs who have different levels of living on one campus. And then also standalone nursing homes, assisted livings, and some other community-based groups that provide services in the broader community, hospice care, and those kinds of opportunities. So as an association, we provide information, education, a lot of opportunities for folks to connect to one another, and then advocacy. We really seek to be the voice of not-for-profit providers, working to make Maryland a better place to grow old for everyone. Next slide, please. So the effects of COVID-19, and I'm sure some of these things you all have heard about, and Chair Kelly introduced some of the issues around workforce. So I just wanted to highlight what some of those challenges have been. Workforce has been a challenge in our field before COVID, and the pandemic has just challenged the workforce even further. And as Chair Kelly mentioned, the majority of the individuals who are in this workforce are women, and many of them have children that are school aged or are caring for aging parents. And so they're not only caregiving at work, but at home. And so that the pandemic has really stretched that group of individuals even further. So a recent survey completed by ARPA and Cal found that 99% of nursing homes and 96% of assisted livings are facing a staffing shortage. We see that here in Maryland. You can talk to any community, any home and community-based services provider, any hospice organization, and they are struggling to find enough staff. And then nearly every facility is asking staff members to work overtime or extra shifts. So not only are we struggling with finding folks to hire, but our workforce that is so dedicated is being really strained. And then 78% of nursing homes and 71% of assisted living providers are concerned workforce challenges could force them to close. And more than 70% say that lack of qualified employees could force them to close their doors. And unfortunately, that's something that we will see here in Maryland as well. I know of at least one provider that has closed in the last month in Maryland, and we need these aging services providers. Our state needs them. So it's something for us to all be thinking creatively about. And then the other top challenge that we've seen throughout COVID-19 are just the increased costs of operating. And that's kind of coupled with decreased revenue. So providers have faced increased costs for things like testing, PPE, staffing, and providers have received some relief funds, which has been helpful. However, many of these costs are going to be ongoing and they're continuing to challenge providers. So I just provided some details here on some of the costs, but testing continues to be an expense, additional PPE, and then staffing is really going to continue to be an increased cost for providers. Next slide, please. So I just pulled a few things here, and some of this will mirror what Sam shared previously. But we have seen some small rate increases from Medicaid for home and community-based services. There are ARPA funds that are, so Sam had mentioned the FMAP bump that we're seeing there. And then there's some information here on Maryland's initial HCBS spending plan. It notes that the Maryland General Assembly responded in its fiscal year 2022 budget, putting certain limits on how the money could be spent. So 75% of the funds will be spent on a one-time rate increase, and the remaining funds will be spent on waiver slot expansion and other efforts to ensure the enhancement, strengthening, and expansion of Medicaid home and community-based services. Next slide, please. I also wanted to note a piece of federal legislation that we are particularly excited about, the Choose Home Care Act. This has been introduced in the Senate, in the House, but not yet the Senate. And so this bill proposes to provide additional skilled and long-term care services in an individual's home or place of residence. And so certain eligible patients would be referred to a home-based extended care, qualified home health care agency. This would not include every home health agency, so it wouldn't be available everywhere. But starting from hospital discharge, Choose Home services would be covered for 30 days, and traditional home health services can continue beyond the initial 30 days as clinically indicated. And this would include the individual receiving traditional home health benefit services, and for 30 days, this expanded package of services, including transportation, meals, home modifications, remote patient monitoring, care coordination, discharge planning, respite care and caregiver support training, additional nursing and therapy care as needed, and personal care services. So the goal here is giving folks an opportunity to, instead of go into an institutional level of care, to be able to receive that care in their home and those wraparound services that would make that possible. Again, this is something that's still under consideration and has not moved yet, but just wanted to make the committee aware of this. Next slide, please. So I just wanted to note a few policy recommendations here for your consideration. Really important. I know that that this joint committee is already engaged in this, but expanding access. So we did support House Bill 1163, Senate Bill 642 in 2020 that did not pass. And we really encourage the legislature to revisit this bill. It would require the Maryland Department of Health to conduct a specified study that provides a cost-benefit analysis of expanding access to LTSS through home and community-based waivers. So there's quite an extensive waiting list of individuals who are wanting to receive these services. And we think it's important that the state continues to work on ways to remove that waiting list and have individuals be able to access the services that they need. A couple of other items I wanted to mention. Continuing Care at Home is a program that sits under the Department of Aging, and it's a model that allows an organization to offer almost like an expanded long-term care insurance policy, where it can either be part of a CCRC model or a standalone organization where an individual pays kind of an upfront joining cost and then monthly fees, but they're then insured to have access to certain services. They have access to care navigation. They receive skilled nursing or assisted living care if they should need that, home care. This is a model that has really taken off in some states, but it has not taken off in Maryland. And we have the regulations in place. We have identified a couple of barriers that we think, if they could be addressed between the Maryland Healthcare Commission and the Department of Aging, could increase opportunity for additional providers to offer this service. And so we would welcome any interest or conversation from anyone on the Joint Committee to have conversations further about that. And then I just wanted to mention PACE. So this is a small but growing Medicare and Medicaid initiative aimed at keeping frail seniors out of nursing homes. And we're very excited that that Maryland is expanding this to potentially 3 additional PACE sites in Maryland that could serve up to 600 additional older Marylanders. And so we know that there are several groups we are aware of and some of our members that are working on submitting proposals. And that is something that we just encourage the Joint Committee to continue to support and find ways to expand further in the state. Next slide, please. And then as it relates to workforce, I think this will take many different approaches to help us reach solutions that actually work. We did support the Direct Care Workforce Grant Program, which the legislature approved last session. So this, I think what the initial investment was $50,000 in matching grants that organizations could apply for. We understand that there will be a request for proposals hopefully in early 2022, but just additional funds for that program could be helpful to support pilot opportunities across the state. And then expanding access to affordable quality childcare and adult daycare. So like I just mentioned, the majority of these direct care workers that we're so short and that are so stressed are women, and they're balancing childcare, caring for parents, other family members. And so all that we can do to support their life outside of work will make it easier for them to be in the workforce and supporting these very important parts of our sector. And then I think provide an expanded role for the Maryland Department of Aging to assist in workforce efforts. So engaging the 12 local workforce areas in the state, convene a workforce stakeholder group, including the associations and the work that's already happening across the state. I think if we can find ways to build into our curriculum in public schools, in community colleges, opportunities in aging services. This is just something that children are not aware of. Kids don't go into 3rd grade saying, I want to be a nursing home administrator or a social worker when they grow up. But if we provided more information on those opportunities and what those career paths looked like, we could get to a place where that is a reality. And then certainly increasing wages and investing in professional development opportunities is key as well. We need these to be real career paths for folks. and not opportunities where people work for a couple of years and then move on to something where they can make more money or move up. We need to build that into our systems. Next slide, please. I'm happy to take questions, comments, concerns, and would welcome the opportunity to speak with any of you further. Thank you.
Thank you so much. While I give members a chance to raise their hands if they haven't, oh, I see some already. So first we have Senator Augustine, and then we have Delegate Solomon. Senator Augustine?
Thank you, Chair Kelly. Thank you for the presentation. I wanted to know where the where they were located and what type of business that they were, if you would.
Sure. Our members?
Yes, the member that you mentioned that had closed down.
Oh, that had closed. The one that I'm aware of is in the western part of the state, and St. Joseph's Nursing Center. And I don't have a ton of detail, but I know that that's just within the last month or so. And that's a part of the state that has been particularly affected in kind of the healthcare realm. There's lack of individuals to come work in that area of the state. There's additional workforce shortages. So that's unfortunate and something that, we should just all be aware of. And does that answer your question?
It does, but are they a skilled nursing facility or that's what
skilled
they are?
Nursing? Yes.
Okay, thank you. Yes, thank you very much. Thank you, Chair Kelly.
Absolutely. Delegate Solomon.
Thank you, Madam Chair. Allison, thank you for the presentation. I had just a quick follow-up question on the PACE program, and maybe we can talk more about it offline, but I was actually literally just yesterday having a conversation with a provider in our area that's really interested in engaging more. I think they're actually taking a visit to a PACE program in another state to get a sense of whether it's a good fit. So could you talk a little bit more about some of the barriers? I mean, is it just funding at this point, or what do we need to do to potentially increase the number of folks in the state that are taking part in that program?
Yeah, so the barrier in expanding PACE in Maryland has just been the amount of funds and kind of slots that the state has allowed. So for many years, there's been one PACE site in Maryland through Hopkins Bayview, Hopkins Elder Plus, and that program has been in existence for exactly probably more than 10, 15 years and has been very successful, but it is limited growth. So it hasn't been an opportunity. This is the first time in years that the state has invited other PACE programs to apply open in Maryland. So we're excited that that the opportunity is there. And the three areas that the state is looking to expand PACE sites are Baltimore City area, Montgomery County, and PG County. And they've also said that they would also be open to exploring some rural PACE sites. But I think one of the barriers with PACE is having enough enrollees to make it a break-even point for providers. So that can be a challenge. And I'm certainly not a PACE expert, but there are PACE experts at the Department of Health that I know would be happy to speak with you all further.
Great, thanks. I'll follow up with you, but I appreciate the run through. Thank you.
Yeah, my pleasure.
All right, we have a question from Senator Benson.
Thank you very much. I thank you for your presentation, but here's I have a niece that's up in Western Maryland, and she has a number of friends who have little children. One of the biggest problems that they are facing is daycare centers that are affordable. The ones that the daycare center that's been taking care of her little girl is closing down. So everybody is, the question I want to ask right now is, what can we do in the way of adding more money so that the daycare workers will have a decent pay? Because they come and they work, and then within the next couple of years, they're gone. We can't keep those workers who really are committed to our children, but we're not paying them the kind of decent salary to even keep the daycare centers moving along. I'm just wondering, what can we do with all the money that's come in from the federal government to raise the bar relative to pay and the working conditions of those daycare workers. What can we do? What can we here in Annapolis do?
That's a great question. And I'm certainly not a childcare expert, but I am a mom of 2 children, so I have firsthand experience. There are funds that went right to the state. There were funds that went to the localities. And I think that if there is a way that we can find some creative initiatives that might be able to be kind of employed at that local level, that could be helpful for some of those areas that are really stretched thin. I will just mention that in terms of childcare, and I'm not an expert on the childcare regulations in Maryland, but I have members who are really interested in opening childcare spaces as part of their retirement community campus. But what I have heard is that the regulations are so burdensome that it just would not be possible. But how amazing would that be if, on an assisted living campus or retirement community campus, there could be childcare for those staff. And that could be a reality that is part of their their salary, is that they get that reduced childcare, free childcare, and that would remove a huge burden for so many people. Again, it sounds like there's regulatory barriers there. So perhaps that's something that this joint committee could explore further.
It's so interesting that you bring that up, Allison, because I know that at the high school level, there's a lot of partnerships with nursing homes and the community groups among the high schools, and that there's tremendous benefit for that intergenerational exchange anyway. So that idea may actually intersect with your other idea, which was let's get this part of our curriculum. And I know we have a lot of folks who specialize in education on this committee. So I just want to toss that idea out there. Senator King has a question.
More of an opinion than anything. We've looked at this several times, trying to find ways that we can do it. And then we run into the burden or the barrier of, do we want to lower our standards for people that are taking care of our kids? And that's why we've always kind of hit a wall with it, because we don't want to lower those standards, and haven't found a way to work that out.
I will say, and I see Senator Eckert has her hand up as well, that I also spoke with a hospital recently who has been looking into opening a childcare on site there, because it's the same workforce issue that they're trying to address. So I think we're going to be hearing more of this. Senator Eckert.
Thank you very much. Sorry I'm late to the meeting today, but we're doing a lot of planning locally. I just wanted to share that Delmarva Community Services in our intergenerational center that is about to be open next week has both a daycare center in it, and it is a senior center and developmental disabilities. So we have all age spectrums, and it's worked with the 2-gen model. So we will let you know. And it's something that we've wanted to try for many, many years. It's been successful in other states. So we're finally getting here. So stay tuned. Just comment on that. Thank you.
No, that's really exciting. Can't wait to hear more about that. I'll see if we have any more hands up, but if not, I have 2 questions. One is just a follow-up to Senator Benson's question about workforce issues. And that was, you mentioned in your recommendations a little bit about the new workforce grant program. And I don't know if you could tell us a little bit more about that, because you recommended increased money. So how is that going to work? So we can keep an eye on that. And then the second is a much bigger picture question. So answer the workforce one and then the big picture.
Sure. So you know what? We are still trying to find out. All we really know is what was in the legislation, that there is this money, that it will be available for matching grants for organizations. And all we've been able to find out so far is kind of a timeline, that we think it'll be early in 2022 that we'll have more information. So I'm happy to report back once we kind of know how that's going to be operationalized. I think that's still being figured out. So that's all I know at this point.
That's all we know too. So thank you for keeping us informed. So my other question is related to one of your other policy suggestions, which you had mentioned, House Bill 1163, which would, again, is aimed at getting at that sort of wait list for at-home services, right? So my big quick picture question, based on sort of what we heard from NCSL, and I would imagine what we're going to be hearing from Medicaid, who's coming up after you, in your position, where do you think Maryland is in terms of offering home and community-based services versus institutionalized care? Are we in the middle of the pack? Are we kind of behind other states? Are we leading the way?
Good question.
Yeah, where do you think we fall?
Yeah, that's a good question. So Leading Age has 38 other state affiliates. And so, I hear kind of snippets of what's happening across the country. I think we're probably somewhere in the middle. I think there are states that are doing really innovative things or have taken very progressive approaches to expanding HCBS. But I think that Maryland is doing a lot. And I think with the expansion of PACE and some of the other things that I know folks are working on, we are making, I think, the progress that we need to make. But, it's unfortunate that there are individuals on these waiting lists that could benefit from the care now in the community, and we want to keep them in the community. So I think that time is of the essence in making things available now and not waiting until they're not able to receive that care in the community any longer. I don't know. Does that answer your question, Delegate Chair?
I think so, but we're somewhere in the middle of the pack. There's more we could be doing, but we're not in the worst shape ever.
That's not scientific, but based on my understanding, that's what I would say.
Excellent. We have a question from Delegate Solomon and then Senator Hedelman. Delegate Solomon.
Thanks, Delegate Kelly. Appreciate the opportunity to get one other question in. Elson, the one thing I forgot to ask earlier, you had mentioned ARPA in your presentation, and Senator Benson's comments sort of jogged my memory. I know one of the things we've been fighting for with MSDE is to get them to use some of their childcare funding on just strengthening the provider network and salaries and benefits, and that's a whole separate. But on for you in this field, I mean, is there conversations going on within the agencies? Or have some of your providers chosen to use some of the ARPA dollars? Is it possible to use that specifically on salaries? I know you mentioned salaries, right, so that's a broader conversation, but for what you've got now or what potentially could come, is there an opportunity for workforce improvements with that?
Yeah, I'd have to look at the specifics of how those ARPA dollars can be spent at that local level, but it's my understanding it's pretty broad and that could be a possibility. I am not aware of any of our members or any providers in the state that take advantage of those ARPA funds directly. So that's something that we're really interested in, is how can we act better with those local councils and mayors and county executives to see if there's ways that we can advocate on how those funds be used. And they can be given to nonprofit organizations, and that's who we are. So are there ways that we could help really make a difference with some of those funds? But I have not heard of any use of those funds yet for those purposes.
Okay. All right. Thank you. Thank you, Madam Chair.
Absolutely. Senator Hedelman.
Thank you, Chair Kelly. I just want to follow up on Delegate Solomon's question. I know that this industry has been having real workforce issues, and I'm just wondering if the providers that you represent have dug into that and have had any success. For example, if they raise wages, are they having better luck attracting and also maintaining their workforce? And related to that, how about in terms of enhanced training or anything else and recruitment efforts, if you could just shed a little light on that, what's working?
Sure. Yeah, sure. It's something that we talk about continually with members, is what's working, what are the challenges. So it's so multifaceted. I think that part of the issue is that it's, these entry-level positions, so CNA, GNA, dining, housekeeping, they are positions where there's a lot of competition from other employers. So those folks could go work at Costco or go work at Starbucks or McDonald's and probably have a lot easier job. And the goal of being a direct care worker is not easy. And with the reimbursement rates the way that they are, it's difficult for providers to say, well, let's just raise everybody's wages. So there's some challenges there. We do have quite a few members who have taken a very progressive approach in raising their wages. Even that doesn't solve the problem, because those individuals, there's so much competition with hospitals. I mean, you can look at some of the sign-on bonuses that hospitals are offering. I heard of a hospital offering a sign-on bonus of $30,000. So there's no way that a home care agency or a hospice or a nursing home can compete with that. And so there's just a lot of competition, and it's not just about the money. That's certainly a piece of it, but many of our members are working towards offering higher wages across the board. They've already taken that step. They offer phenomenal benefits. So recruitment is, you know, a lot of folks are using creative advertising on social media. They're doing drop-in job fairs. They're doing kind of everything under the sun. And it really is, it's just a challenge. There's so much competition for that workforce and they have so many options. And our field is not an easy place to work. You really have to be passionate. You really have to care. You have to want to do it because there's easier places to work. So I know that doesn't answer your question, but our members are continually trying to find creative ways to address it and to bring people in. And the point you made about development, a lot of our members offer very robust scholarship opportunities, tuition reimbursement, even sometimes helping to pay off student debt to hopefully entice people to join.
All right, I think our next question is from Senator Carrozza.
Thank you, Madam Chair, and Allison, thank you for your presentation. My question is to Allison, but I saw two of my colleagues, Senator Eckert and Senator King, that I think have been involved in this before, so anybody can kind of chime in. But you know, we seem to be zeroing in on the severe and acute workforce shortage with our long-term care workers. At the same time, we've had, you know, good questions about how we might be able to use, you know, the ARPA funds for salaries and to specifically address the workforce shortage. And I heard one remark about how that's the key to that will be to find the appropriate local partners. And I guess where I'm going with my question is, I know, for instance, in my district, I represent Somerset, Worcester, and Wycomico, and our Tri-County Council has been working very hard on, have made this a priority, but it absolutely is coming down to these partnerships. And I think we have to be sensitive that we don't, we have to almost approach it the way the locals would, that we're focusing today on long-term care workforce shortage, but we also know that the shortages are in other areas of healthcare, nurses, doctors, therapists, counselors, and we know that the workforce shortage is in every other major industry, hospitality, construction, public safety. So I guess my question is, not knowing the reach of Leading Age Maryland, you know, how you've been able to maybe see how these different pieces can work at the level. And I also, if Senator Eckert or Senator King, who I know have worked with some locals prior to COVID, have some thoughts on how we can really leverage our local partners with this.
So I want to just be sure I understand your question. Are you asking specifically about how we've seen some of these local partnerships more broadly, or with reference to the ARPA funds?
Well, specifically with the workforce shortage issue, it's not as familiar with Leading Age Maryland to know what your local partnerships have been across the state. I heard a little bit about Western Maryland. I don't know what they are on the Eastern Shore. And then again, I really think that's going to be the key to it, that we all seem to agree on the issue as far as the problem. And we know that locals are key to it. We have this, you know, for a limited time, these federal funds coming down, but the key is going to be, I think, the local partnerships. So probing you a little bit on where your partnerships are across the state, especially on the Eastern Shore. And then if my colleagues, any House or Senate, had any thoughts on this.
Yeah, that's great.
Allison, before you answer, Senator Eckert does have a comment also. So answer what you can, and then we'll go to Senator Eckert.
Okay, I would say that, so we do have members on the Eastern Shore, both affordable housing members and retirement community members. And many times the leadership teams there in the campus and the community itself is very well connected with local government, with local community. And so I would say that's where our Leading Age Maryland partnership is. It's through our members who have those local relationships. So it's certainly a network that we have, but it's not something that, yeah, does that make sense? So it's kind of through our members who are in those communities, and we have members in every part of the state. So it's very geographically diverse.
Let's hear from Senator Eckert if you have something to add to Senator Crow's question.
Thank you very much, Madam Co-Chair. I would just like to add there are a number of things that we've been working on already in relaxing some of the standards without sacrificing standards through the Board of Nursing with regard to getting CNAs and other health professionals into the workforce. One of the best things, though, I think that works well is to work through the EARN program. That's been very useful. It's businesses get together and then use some of those funds out of the Workforce Investment Board. The other issue is credentialing. If our schools are technology programs where we have CNA programs in our high schools in Dorchester County, we have, when our CNAs graduate, we graduate about 18 to 20 every year. When they finish their program, they can enter the workforce the next day, step into jobs because their certification exams already completed at that time. And it's the fingerprinting, everything's been expedited through the Board of Nursing. And I think that's a great model. I know we're establishing other programs in our other counties, or we already have existing programs. One of the issue is to get qualified seasoned nurses to be able to be mentors for that certification exam when it's taken. So I think we've been trying to approach this from a number of different avenues, and it will only, as each group graduates, and then working more closely with our community colleges to build on that, I think it's going to be one of the ways we are able to address this.
Thank you, Senator Eckert. And then I just have one more question for Allison before we let you go, and it's pivoting from these workforce discussion back to the sort of provision of care, since we're talking about these two sort of different spaces that are both really important. But a lot of your recommendations, I think you're able, unlike many of the other stakeholders, because of Leading Age is representing sort of the CCRCs and the senior housing and the nursing care facilities, you can see this different sort of continuum of care. So I'm just, I guess, wondering if you can tell us a little bit more before we hear from Medicaid about sort of what is happening on the ground in Maryland in terms of, again, what NCSL mentioned to us, which is this national shift. They're seeing that people are more preferring to receive their care at home if possible. You know, are you hearing things from different members about, you know, in addition to the specific recommendations that you made for the policies, which I think are very helpful in guiding us, but just sort of any closing thoughts sort of in general about where, you know, if our wait list being long is a problem, you know, if the standard that we're sort of fulfilling here in Maryland could be improved. I'm not trying to fish for an answer. I have heard, you know, on multiple occasions for many, many years now that the fact that we sort of depend on people going into nursing care and then going back to the community is not ideal. And that the fact that we have extremely long wait lists to get on one of the community-based services waivers is not ideal. So I'm asking you before we hear from Medicaid, if that's sort of the sense within the professional community as well.
Yeah, it absolutely is. I think, you know, maybe what I'll share is I had a conversation with a group of our housing members this morning, and there's really this gap in, you know, in affordable senior housing. There's individuals who are living independently, no kind of wraparound services or supports necessarily, maybe service coordination, maybe not. And these individuals don't need a nursing home or assisted living level of care, but they could stay independent a whole lot longer if they had help with housekeeping, if they had help with some ADLs once in a while, if they had some really kind of small services that probably would not cost a whole lot to offer. There's some really interesting grant-funded programs that are happening in Maryland to provide care navigation on site in partnership with service coordinators. So I just think that, yes, we really need to figure out how to provide that higher level skilled nursing care in the home for folks that are able to receive that kind of care in their home, and it's beneficial for them. But I think we need to think even further back from that to people who don't even need that type of care yet, and what can we be doing to be proactive? And so people are able to stay healthier longer. I think a lot of times we think we're very reactive in our medical care here. And if there's ways that we could creatively fund initiatives that could help people stay independent longer, we wouldn't need to use as much Medicaid dollars to pay for these other things. So I guess that's just what I would close with.
No, that's really, I really appreciate that. And thank you for your perspective. And I think you can tell from how engaged the committee was, we really appreciated your presentation. So thank you very much.
My pleasure.
Now we're going to move on to hear directly from Medicaid. So first we will hear from our friend Steve Hsu, who is the Deputy Secretary for Healthcare Financing and Medicaid. And then after that, we will hear from our friend Bernie Simmons, who is Deputy Secretary for Developmental Disabilities Administration. So Deputy Secretary Hsu, welcome. Thank you so much. Are you here?
Good afternoon, Madam Chair and members of the committee. It's a pleasure to be with you. Appreciate the opportunity to present to the Joint Committee on Children, Youth, and Families regarding MMAs, or Maryland Medicaid Administration's long-term services and supports. For the record, I'm Steve Hsu, Deputy Secretary of Health Financing and Medicaid. If we could go to the second slide, please. Our most immediate priority is, no surprise, the ongoing response to the COVID-19 pandemic and the challenges it has and continues to represent. To that end, we're focusing on ensuring that every Marylander receiving Medicaid benefits receives outreach and opportunities to get vaccinated and tested as needed. To date, we have vaccinated more than 7.8 million vaccinations administered. As of October 4th, 84% of the 18+ population received at least one shot. 96.5% of the 65+ population has received at least one shot. And those numbers have risen in recent days. We've made telehealth an integral part of many of our programs. We've also taken various actions to extend many COVID-related flexibilities to support our providers, and we remain committed to increasing vaccination rates for our Medicaid beneficiaries over the next 90 days, and ensuring that long-term care Medicaid beneficiaries in congregate care facilities have the opportunities for vaccines. Next slide, please. MMA directly administers or indirectly oversees the operation of approximately 20 programs under the umbrella of the Office of Long-Term Services and Supports, or OLTSS. These programs provide services and supports to the elderly, people with physical or intellectual disabilities, chronically ill children, and people who are duly eligible for both Medicare and Medicaid. Next slide. LTSS's services are rendered under various Medicaid authorities, including the Maryland Medicaid State Plan, our optional state plans, our Medicaid 1915B and 1915C home and community-based services waivers, and our Medicaid 115 waiver. The earlier presenter did a very nice job laying out those federal authorities. I'm going to copy that slide for future presentations. Next slide, please. The Medicaid program supports 8 waiver programs administered by 4 different units. The first waiver is the model waiver, which was established in 1985 and is administered by the Office of Long-Term Services and Supports. Programs under this waiver serve medically fragile individuals with no minimum or maximum age limit, but individuals do have to enroll prior to age 22. Next on the table is the home and community-based options waiver, established in 2014 and also administered by OLTSS. This waiver serves individuals ages 19 and older who have a physical or age-related disability. Moving down the table, we have the Medicaid Day Care Waiver, established in 2008, also administered by OTSS. The medical day care waiver serves individuals 16 and older who have a physical or age-related disability. Next is the Community Pathways Waiver that was established in 1984. This is administered by the Developmental Disabilities Administration, or DDA. You'll be hearing from Director Simon shortly. This waiver serves individuals with developmental disabilities, and there is no minimum or maximum age limit. The next one is the Family Supports Waiver that is also administered by DDA. This waiver serves individuals with developmental disabilities ages birth to 21. Next is the Community Supports Waiver, again administered by DDA. This waiver also supports individuals with developmental disabilities, and again, there is no minimum or maximum age limit. Second to last on the table is the Autism Waiver, established in 2001. This is administered by the Maryland State Department of Education and serves individuals who are diagnosed with autism spectrum disorder and are between the ages of 1 and 21 years old. And then lastly is the Brain Injury Waiver, administered by the Behavioral Health Administration of MDH. This waiver serves individuals who are diagnosed with a brain injury and are ages 22 or older. Next slide, please. Under Maryland's Medicaid state plan and the 115 waiver, OLTSS operates 9 additional programs, including the Community First Choice Program and the Community Personal Assistance Services Program for adults with physical and/or age-related disabilities so that they can live in their own homes. The program of all-inclusive care for the elderly, or PACE, which was discussed earlier, enables older adults with serious healthcare needs to remain in the community rather than in an institution. The Private Duty Nursing Home Program, which provides nursing services to children and adults who have continuous nursing needs to enable them to stay in the community rather than in an institutional setting. Home healthcare program is for people who need skilled nursing services on a part-time intermittent basis. NEMT, or non-emergency medical transport, which provides Medicaid participants with transportation to planned, that is non-emergency, covered medical services when no other transportation resources are available. The Durable Medical Equipment, or DME program, provides medical equipment and supplies to individuals with qualifying needs. The Nursing Facility Services Program, which provides residential care for individuals with a nursing facility level of care requirement. The Hospice Program, which provides palliative end-of-life care in institutional and community settings. And lastly, the various increased community supports for people with physical and age-related disabilities. Next slide, please. COVID has had a very significant impact on OLTSS programming and on the people we serve. We've seen significant fluctuations in the utilization of services. Many nursing facilities saw a significant decrease in services, whereas home and community-based services saw an uptick. Prior to the pandemic, there were 26,019 waiver and CFC participants, and currently there are 26,779, an increase of 760 individuals. Additionally, providers are reporting significant staffing and workforce challenges. We're hearing this with tremendous frequency. But despite the challenges, providers remain focused on health and well-being of program participants while carefully balancing the safe reopening and restoration of their day program services. We continue to work with the Developmental Disabilities Coalition, which represents the providers in the DD community, and other stakeholders to assist families and providers with their business readiness and reopening strategies. Next slide, please. The Maryland Department of Health is working very aggressively to respond to the COVID crisis and to mitigate the impacts of the pandemic. As required by federal maintenance of effort rules, we're maintaining participant eligibility in all programs. We have provided temporary flexibilities to providers to address service delivery, workforce shortages, and provider capacity issues. These actions include allowing legally responsible individuals to be paid for personal assistance services, relaxing various provider hiring and training requirements, allowing telehealth and remote services, and advancing provider rate increases as quickly as possible. Additionally, Maryland continues to be a national leader on the vaccine equity front. We rank 6th in the nation for vaccination rates within the Black population and 6th in the nation within the Hispanic population. Next slide. The American Rescue Plan Act, or ARPA, provides financial support for Medicaid home and community-based services. This act, as you heard earlier, includes a 10% enhanced federal match, or FMAP, for 1 year ending March 2022. 75% of these funds will be allocated to provider rate increases, as you, the legislature, have directed. All funds from ARPA must be reinvested by March of 24. That concludes my remarks. I would be happy to answer any questions when that point comes in the work group here today. And again, I want to thank you for having me, and I'll turn it back over to you, Chair Kelly.
Thank you. Do we have any questions from the committee for the Deputy Secretary? I see Senator Carrozza.
Thank you, Madam Chair, and I'll make this brief. I was excited to report this earlier, but wanted to do this with our Medicaid Director, Steve Hsu here. Earlier today, I attended a partnership with the unveiling of a Healthy Homes initiative. And the partners were the Atlantic General Hospital, the Worcester County Health Department, and the Chesapeake Housing Mission. And what they did is they rolled out this partnership to focus on tying health initiatives to improving places where people live. And they this is the first that's being rolled out in my one of my counties in my district. And the research shows in other states, and this is why I wanted to flag it for our Medicaid director, that for every dollar spent on home repairs, it saves $19 in Medicare, Medicaid costs. And when they also, what I really liked about this program is they track their outcomes. So after they provide a service to these homes, they go back later, a year or two later, and look at the outcomes. There's been a 95% reduction in falls, 11% reduction in hospital admissions, 47% reduction in emergency department admission charges. So the numbers are panning out. So my question is trying to link what you just reported about. We've got the ARPA funds that provide for Medicaid home services and these partnerships that we're putting together to see if that is something, number one, that we can encourage more healthcare workers to be aware of this type of program, and to also see if these type of partnerships then are eligible for those ARPA funds.
Well, thank you for attending that event and for sharing your experience with us. That's very exciting to hear. And we are very interested in supporting those kinds of programs. I will need to explore with our CMS experts whether ARPA funds can be used in the manner you're describing. As you know, there are a lot of strings attached to ARPA funds. We've received a little over 500 million, we believe, rough estimates in enhanced FMAP, and that's being channeled to into DDA, into LTSS, and into BHA. So there are 3 channels directed by the legislature to which we've sent those funds. And each of those 3 administrations is making independent decisions about how to allocate those resources. But I will circle back to you and the chair with my findings on whether ARPA funds can be used to support improving people's homes for these purposes.
Thank you, Madam Chair. I'll share that information, Madam Chair, with you and with our director. So it may be helpful for other members in their district as well.
Yeah, thank you.
Thank you so much. Delegate Solomon.
Thank you, Madam Chair. Deputy Secretary, thank you for being here. I guess the question sort of less directly around home-based services, but more sort of broadly piggybacking off of the conversation we were having with the previous presenters around workforce issues. And I'm just sort of curious, I mean, one of the issues we keep hearing in childcare, and I'm sure this is an issue in the, in the aging workforce as well, is obviously, a lot of these providers are nonprofits that have great difficulty in providing health insurance benefits for their staff. I was talking to a provider earlier that was saying beyond salary, just providing health insurance is their number 2 cost. And so I don't know if this is something that you're thinking about, but sort of the department in general, are there any creative ideas or proposals being floated around? I mean, it's something I've been talking with some of the provider community groups about, some sort of role for the state to step in and play to, to identify these workforces as frankly more important or, a public good that we need to be able to provide some sort of health insurance system for them that is not just falling, solely on the backs of providers to be able to pay for it, but a recruiting tool, a way to show this workforce, you should stay here because there are benefits that are in that you're able to get. And again, I don't know if there's any sort of creative thinking going on within the executive branch around this, but it's definitely something that I've been spending more and more time on, and would be curious to get your thoughts on it as well.
Yeah, thank you for your question. We are very concerned about the workforce-related stresses that all of our providers are experiencing, not only in home and community-based services, but in the within the behavioral health community as well. We are taking a number of actions to support providers. Most importantly, the very substantial provider rate increases that will result from the enhanced FMAP. We're still running those numbers, but they're going to be very substantial pay increases, and that's going to help a lot, I believe. Also, in the specific case of the behavioral health providers, as you may be aware, the providers owe the state a cumulative $230+ million resulting from overpayments. Going back to last year, the state was estimating payments to providers based on their historical billings instead of actual claims, but claims were way below expectations because of COVID. And here we are today as a result of that misalignment with about $250 million owing from the providers to the state. We just announced in the JCR that was filed on Friday that we are going to begin the process of collecting those funds, as we must do for the taxpayers, and to be able to channel those dollars back into providing care to the citizens. But we wanted to make that process as easy as possible for exactly the reasons you're saying. So we are offering the provider community 1 year to pay us back at no interest. We informed them of that in a town hall yesterday, and they were very, very pleased to hear that. We're also, as part of that process, going to forgive providers with small balances of below $10,000, 100%. So they will be completely forgiven, and that will disproportionately help the small providers who are under the most stress under these circumstances, and that will clear 900 providers of owing anything to the state out of about 2,400. So it's a very substantial forgiveness program. So we are doing everything we can. I am not aware of specific discussions about a state-driven insurance program. Beyond what we have in the case of Medicaid. Medicaid is the second largest insurance company in the state of Maryland, and it's there providing care to 25% of the state. But I would imagine that given eligibility requirements, that most of the people employed in the industries that we're talking about would probably not be eligible.
Thank you.
Thank you.
I'm going to see if any more members have questions. Right now, it's just me, and I have 3, and I apologize, but I've been holding them, and more people have been getting me thinking. So to follow up on Delegate Solomon's question on the proposed rate increase, I have been hearing a lot of conversation about about the different ways that rate increase should be structured. So can you give me an update? Is it just going to be 75% increase being sent to the provider with no connection to a career ladder or no guaranteed wage pass through? Is there going to be any guarantee that this money is going to the workforce?
Well, the answer is different depending upon which of the three channels, BHA, LTSS, and DDA. In the case of DDA, they all have one thing in common. The 75% is all being channeled to provider rate increases. It increases their reimbursement rates. From there, the money that they receive from us is used to support their operation, including payroll, but also to pay the light bill and the gasoline and everything else that is required to run their operations. We do not direct down to every line item of their P&L how they need to use those dollars. But in the case of DDA, we're not doing a simple rate increase. With the developmental disabilities industry, we're going to provide a retroactive called a catch-up payment of 2 quarters worth. That will consume a significant percentage of the money that is available for provider rate increases. And then the balance of it will be spread out over the next 3 years. All this money has to be spent by fiscal 24. So over the next, out until fiscal 24, the rest will be spread. In the case of LTSS and BHA, the payment mechanisms in those industries don't allow that retrospective catch-up type payment, so we can't pay in arrears. It's all going forward, so it's a smoother payment plan that unfortunately has the disadvantage of not getting as much money into people's pockets as quickly as we would like to. The beauty of the DDA mechanism is it lets us put a significant chunk of money into providers' pockets right when they need it to rehire staff, improve their pay scales to attract people back to their businesses.
Okay, super. So let me just get to my other 2 questions because I know we have more to hear from, but I think we heard from the last presenter how important both childcare and adult daycare is to solving the workforce issues. So I have a question about particularly our adult medical day program. Can we get a status update? I know we had some conversations in the last few months about the administrative rate. So can we get an update on the administrative rate for adult medical day? And then also in terms of what happens if someone shows up to an adult medical day program and has tested COVID positive, if it's an entirely vaccinated population. From what I understand, similar to the problem that many of us have been seeing in our local school districts, I think those programs have been forced to close down the whole program if one vaccinated person with a breakthrough case is positive shows up. So can you talk to me about how that's working on the ground? So an update on the administrative rate and also COVID protocols and whether they're having to close again if a vaccinated person with a breakthrough case comes to the program.
In the case of the administrative day rate, we, as you may be aware, extended the 85% payment plan out to September 30 with the intention of staging it down over a period of months and having it retired entirely by December 31st. That requires approval of the federal government through CMS, the Centers for Medicare and Medicaid Services. That approval has not come in on a timely basis. They're kind of backed up over there. So we're standing pat right now at the 85%, and we will stay there for as long as required until CMS authorizes otherwise. It could be days, it could be weeks. Things are taking much longer than we're accustomed to with CMS. As far as the protocol for how we handle a COVID positive arrival into a facility, I'm going to need to defer to our subject matter experts and get back to you about that. I don't have personal knowledge of that level programming.
Okay, thank you. Yeah, I would appreciate if we can continue that conversation, because what I have heard is that it's very similar to what we were seeing happening in Montgomery County Public Schools, but now has stopped, where the whole class has to go home because one person came in and et cetera. So I think that that's been a bit of a problem on the ground. So I would love an update on that. And then my final question, and I'm sorry to take up so much time, but big picture, back to again that first NCSL presentation we saw, that the slide they threw up said that generally across all states, 57% of long-term care funds are going to home and community-based services, and 43% are going to congregate care, traditional nursing services. And I'm wondering how Maryland's mix compares to those federal numbers. I know you mentioned we saw an increase in about 460 people receiving home and community-based services, but I'm just wondering because again, I still hear about wait lists. I recently had a conversation with an elder care lawyer from New York who said, in New York, if you want home and community-based services, you just sign up and you get it, because we want to keep you out of nursing care because it's cheaper for us. We want that. That's the way our program is structured. But in Maryland, it's very convoluted and complicated, and there's no program like that except for the waiver with the long wait list. So I'm just trying to get a better understanding of that situation and where we are in Maryland in terms of what NCSL mentioned was this federal shift towards more home and community-based services.
Yeah, I think the numbers are probably in line with what you're seeing nationally. As I mentioned earlier, a little over $500 million is coming in from the enhanced FMAP. Of that, a little over 200 is earmarked for DDA. So that's about 45%. I think it's consistent with what the numbers you were just quoting. And then the other 300 is split not quite evenly between LTSS and behavioral health.
Okay, but my question was specifically related to within long-term care, how much of our spend is going to nursing care and how much of our spend is going to home and community-based services.
Oh, I see. Okay, I will find out and get back to you about that, Madam Chair.
That would be super helpful. Thank you so much. And I'm not seeing any more hands up. Last call from members. Otherwise, I would just say thank you so much. We really appreciate your time and your being here to answer all of our questions. And we'll move on to your wonderful colleague, Deputy Secretary Bernie Simmons. Thank you for being here.
Well, thank you, Chair Kelly, and all the members of the committee. For the record, my name is Bernie Simons, and I'm the Deputy Secretary for the Development of Disabilities Administration. Next slide, please. So, as you know, COVID has impacted all the residents of the state of Maryland, and that includes all of our developmental disability community. Throughout the pandemic, I've got to emphasize that our DD participants and their families have remained steadfast in their commitment to remaining safe. As an example, to the point where if a family has a son or daughter at home and they're not comfortable with a direct support professional coming into the home, because they weren't sure if that person was vaccinated or not, then they said, no, we will just continue to provide the appropriate supports. So obviously there was a lot of concern about that. Let me report that, and as you can see on the slide, that we've been a great DD community about getting out and getting vaccinated. So we do a survey every other week, and I'll talk about that because we're changing the frequency on that and some of the questions. But we were looking at the number of people that were vaccinated, and the providers go in and basically report on the number of people that they provide supports to who are being vaccinated. And you can see as of today, we've got about 85% of the total number of folks in our supports who are vaccinated. I think that's been an outstanding. Our providers have also rolled up their sleeves and done a great job. And basically, you can see on there, there's been 139 vaccination clinics. They basically partnered with the federal pharmacy program, CVS and Walgreens initially. They've done a lot of partnership with the local health departments, and they've hosted clinics in their own agencies for people they provide supports for, their families, staff, but have not limited to their own group of people that they provide supports to. They've also opened this up to families who are self-directing their services, who basically do not have an agency to go for vaccinations unless they went to one of the MaxVax sites or whatever. So again, I think as a community at home, everybody's done a really good job with moving forward and dealing with vaccinations. There is a few issues though that I want to bring up that families remain concerned about the number of direct support professionals who may not be vaccinated because they've made a huge effort to have their son, daughter, sister, brother vaccinated, and we hear stories about breakthroughs, et cetera. So there's some concern about that, and also some discussion about the Delta variant and what does that mean. So we continue to encourage people to get vaccinated. We know that Secretary Schrader has ordered that all developmental disabilities group homes to offer vaccines and additional doses to its people who live there. And again, we've done that 139, and I think we've done a real good job. I also think that we've had a great opportunity for the direct support professional workforce, especially that has been exacerbated during this pandemic. In an effort to address some of this stuff, you may recall that the governor accelerated the 4% rate increase from not last July 1, but to January, so that it would assist the providers and being able to forecast some of the funding that will be coming in. So as we look at that, we're also looking at the best ways to look at the ARPA funding and how to support those initiatives. And I'll talk about that in a few more slides. And so again, I think the providers have remained very committed to programs and looking at hybrid programs. Now, there's something called an Appendix K that Medicaid, on behalf of the state, submitted to CMS, Center for Medicare and Medicaid Services, and that allowed people to receive remote supports, where the service definitions basically said you had to receive face-to-face supports. And it also allowed for family caregivers and families to be paid as caregivers during this pandemic. And where we are in moving forward with that, we will continue that even after the pandemic to some form. Next slide, please. So since mid-July, the department, Secretary Schrader and Deputy Secretary Hsu, have been meeting with the DD staff and the DD Coalition, basically, and the Department of Disability, Secretary Beatty. And we had weekly meetings. We started twice a week and were once a week. And basically, these on the screen, and I won't read them, but you can see that there are 4 mutually agreed upon objectives. And this work will continue to help guide us as we continue with these meetings and these shared objectives to look at the planning and the unwinding of and reopening and how we get back to a different level from when we see, as we have seen, numbers going down and the number of people who have remained positive with COVID, and we've seen vaccines going up with the number of people who've gotten their shots. So we're encouraged about the partnership with the DD Coalition and their input and feedback and insights. Next slide, please. So in support of reopening, again, we looked at Appendix K, and Appendix K was approved through Medicaid by CMS. That gave us a lot of flexibilities, let us do remote, let us do billings differently. with the amount of hours that had to be taken a look at. But again, what we did is we looked at this and, some things as an example that we put in there was looking at people who could have staff go into a hospital. Historically, I have heard from people in the House and the Senate who have called on behalf of their constituents that said, I've got a constituent who has a family member with IDDs in the hospital and they need one-on-one, and DBA did not have a vehicle for that payment. Now we do. One of the areas that we had worked on and the Secretary moved forward with was the promulgation of the emergency regulations, because right now our billings are for about 6 hours per day. And obviously there's a threshold of providing those services. And the threshold is you need to provide 4 hours to bill for 6. And during the pandemic with Appendix K, it was relaxed to a much lower threshold. So obviously that emergency regulation was important to continue until the end of this calendar year. The other issue, as Deputy Secretary Hsu talked about, is looking at the ARPA money, and obviously he talked about the 3-year plan and the rollout as we continue to move forward with trying to get as much money to the providers as possible so that they can recruit staff and pay sign-on bonuses, increase their hourly rates, et cetera. And so I think, as Steve said earlier, for DDA, it went back a few months. It went back April. It's extended to 2024. But I want you to also remember that in addition to that we have the annual 4% rate for every July in DD that was passed. And obviously, so you get the ARPA money and the 4%. So, that should assist with the providers with reopening and taking a look at where we are as we continue to move forward. We are conducting a rate study. We are in the finishment of that. We should be done extremely shortly and be able to move forward. And we've done that in partnership and discussion with Laura Howe and some of her staff and actuaries from the Maryland Association of Community Services. So we appreciate that partnership and that discussion, and looking forward to completion of that rate study. Next slide, please. So as I mentioned earlier, we were doing surveys initially, and we were doing it basically every other week. And we were looking at the number of people who were vaccinated, the number of people who had passed away, the number of people of staff who had passed away, and the providers were reporting on this very diligently every other week. Some of you may recall that I was doing webinars monthly with the pandemic, weekly, when the pandemic first started. And then after about 14 months into it, we went to every other week, and now we are in the phase of doing those monthly. But we presented that and had the opportunity to have people from the CDC, like Dr. Kenny Fetter, and other people from the Department of Health, Public Health Administration, be on those webinars to talk about safety and COVID, et cetera. And so in discussion, we decided that, okay, now we have this ARPA money coming in, and we probably need to figure out what people are going to be looking for. So you can see that we've done 2 different surveys now. These surveys are completed the 15th of the month and the last day of the month, as opposed to every other week. And the goal, obviously, as you can see in survey 1, is to identify one-time resources that people might be interested in. And we've seen some preliminary data around that. And people are obviously looking at, and the provider feedback is one for recruitment and retention of staff. Another one is for staff education and training. Another one is for the transition of the DBA from prospective payment to a fee for service and changing from our current IT platform to the Medicaid platform of LTSS, so that we're more aligned with the other programs under Deputy Secretary Schill. And so one other area that I think was a little bit of surprise is that the number of agencies that need vehicles. Many of the agencies, when the pandemic hit and they were not going out into the community, basically had rentals for their vehicle fleets. And, so rather than put money out for something that was just sitting in the parking lot, some of these providers decided to end those leases. So now there's going to be a struggle though with seeing that the number of vehicles that would be needed, and knowing that as you see on the nightly news, that vehicles are having a problem for everybody because of the shortage of chips that are needed for the computers in the vehicles, et cetera. So, I think as we move forward, we'll continue to work through this. So that's the first survey. The second one is looking at, so are we seeing any success with the providers and what they are doing with decreasing their either vacancy rate or increasing their workforce? And we've seen a slight uptick, not much. It's very difficult. We know there's a lot of competition out there, as Delegate Kelly was mentioning a little bit earlier, and what we look like. And, there's a lot of competition, and we need to make sure through the ARPA money and the COLA 4% within DDA for the next few years that we get that money out to the providers so that they can build a good workforce and have appropriate amount of money that they can recruit and retain staff. Next slide, please. So this basically gets to, we're going back to April, and it goes through, as Secretary Shu said, 2024, and you can see it's March 31st, and that'll be the 10% increase. And we recognize that it has been a tremendous impact on the workforce, but I think I have to applaud all of the providers who have done an outstanding job through this pandemic. And we work continuously with the coalition around how to direct anticipated resources and funds. And again, it's our goal to get these funds out the door as soon as possible. And with that, I'll end my presentation. Thank you for the opportunity.
Absolutely. Thank you. I'm looking for any hands for questions from the members. While I give them a second to raise their hand, I will just thank you very much for your presentation and for the work you've been doing, both of you. I know it's not an easy time to be doing this work, and we're very, very thankful. On the workforce issues, have either of you been partnering with the Department of Labor to try and come up with creative solutions to help this workforce, or at least sharing with them the concerns about this workforce? Is that communication happening?
I'm not sure.
I'm not sure at what level. I think it might be happening more at a local level with the providers having discussion with the local offices.
Okay, wonderful. And we're going to hear from Rachel London and Laura Howell next, so maybe they can talk about that a little bit too. But I don't see any more questions from our members, which means your presentation was very thorough. Thank you so much. Thank you both, and I'm sure we'll be hearing from you in some follow-up to the outstanding questions. So thank you very much for being here, and let's hear next. Absolutely. Let's hear next from Rachel London with the Developmental Disabilities Council.
Good afternoon, Madam Chair. Thank you. Members of the committee, I am Rachel London. I'm the Executive Director of the Maryland Developmental Disabilities Council. We are a statewide public policy organization that creates change to make it possible for people with developmental disabilities to live the lives they want with the support they need. And we do all of that led by my council or board that is primarily people with developmental disabilities and their families. And so it's from that perspective that I'm going to offer a little bit more information. I did submit written testimony. There are some realities I think that we can't forget, and in order to frame the conversation around the impact of COVID on people with developmental disabilities and their families, and that is really the high risk. In March of this year, there was a publication and a study published in the New England Journal of Medicine that found that people with developmental disabilities were over 3 times more likely to die of COVID. And when you look at people with intellectual disability, not only were they 2.5 times more likely to get COVID, that study found that it was the highest risk factor of all risk factors. And people with intellectual disabilities almost 6 times more likely to die. And so all of that being said, much like the rest of us, people and their families are some tired of being home. Others are struggling to be home and work and care for their loved ones. And others are really just trying to stay home and stay safe and stay healthy and want to stay there, right? And so really all of this is not much unlike the rest of us in one of those 3 categories, but leads to a kind of an uncertainty of what they want, what services and supports people want and need, and how they want to receive those services and supports. And you've heard a lot about the Appendix K flexibilities in all of the waivers. For Marylanders with developmental disabilities, specifically, it really did mean a significant flexibility in the way services were provided and by whom. So while there were lots of flexibilities, I'm going to highlight 2 because those really had a positive impact on people. And those 2 are that families could be paid as staff members. So those families or those people that chose to not go into places or go to work or to even move home if they were living somewhere residentially, their family members could be paid to provide the service and supports they needed. And the second is the flexibility in where services were provided. So the biggest example of that is people whose either day program closed or was only now opening partially could receive some of those day services at home, whether that was at their residential setting through a provider or in their own home. And that not only benefited people and families and had a positive impact, but because, as you've heard, and you will hear more after me, the pandemic really has exacerbated the already existing workforce crisis. And so having the availability of family members to be paid for and provide those service and support has been helpful to providers as well. So you heard already about the partnership between the DD Coalition and the Department of Health. I am the chair of the DD Coalition, so I want to just take a moment and thank Secretary Schrader, Deputy Secretary Shu and Simons, and Secretary Beatty from the Department of Disabilities for taking the time, for continuing the conversations, for the ongoing meetings, and really for the consideration of the recommendations and the thoughtful action that was taken or has been taken and continues to be taken, so that we can all work together and make sure people and families have access to the service and supports they need and want, and providers are able to provide those services in a way that meets those needs. It's critical, though, as not only as the pandemic continues or hopefully unwinds at some point, that we all remain open to considering some of the most beneficial flexibilities continuing beyond the end of the year. I want to switch gears for 1 second and talk about the autism waiver. It was mentioned, but just very briefly, this is not in my written testimony, so I'm happy to provide more information afterwards, but there are over 1,300 children and their families receiving services through the autism waiver right now, and almost 6,000 waiting on the autism waiver registry. What we have heard, what the council has heard, is that one of the most beneficial flexibilities that the Appendix K waiver for the autism waiver, that was a lot of waivers, provided was the fact that transition age youth or those that would have been transitioning to adult services or to the DDA were able to remain on the autism waiver. And actually over the last 2 years, about 145 youth and their families chose to stay on the autism waiver as opposed to transitioning to adult services yet. They are struggling now to not only figure out the process, but also to find the services and supports that they need. And so I think the recommendation really is that as much collaboration and partnership and focus that has been on the DD adult community, mostly in the DD waivers, which again, we're very appreciative, is also needed there. So again, just to end, COVID created these unique challenges for all of us, including people with developmental disabilities and their families, but it also presented opportunities. There were new and creative ways that people were receiving support. And I think the bottom line is we all have to remain open to continuing to provide service and supports in those creative ways and do what needs to be done to best support people and their families. Thank you.
Thank you so much, Rachel. I'm going to go ahead and have Laura Howell with Max come up and speak, and then we'll go to questions since we've only got 13 minutes left. Thank you so much, Laura.
Thank you, Madam Chair and members of the committee. I'm Laura Howell, the Executive Director of the Maryland Association of Community Services, or MACS. We're comprised of over 100 community-based developmental disability providers, and our members receive about 85% of DDA's funding for community services. And we provide all the services that are in the DDA waivers, including community living, employment, meaningful day, respite, personal supports, and any other service that helps people to live and work and thrive in their communities. And as we all know, this has been an incredibly challenging time, and particularly challenging for community providers. I just want to touch on a few of the most challenging components. First and foremost, and we've talked about it all afternoon, is the workforce crisis. Many of our provider leaders, and many of you know them in your communities, have spent their entire careers working in this field, and they all say the same thing, which is that they've never seen anything this bad. And that's really saying something, given that we've seen a lot of tough times in terms of our workforce issues. In May of this year, we surveyed our members about their vacancy rates in May. So very current data, and the results really tell the story. I'm just going to give you one number. 1 in 3 providers reported a direct support vacancy rate between 30 and 58%. Those are perilous numbers. Countless providers have reported that they do not expect to be able to continue to provide supports to everyone they currently serve, absent their ability to hire a large number of direct support professionals. And many are currently operating with hundreds of vacancies, which is unsustainable. So what causes numbers like that? Well, pre-pandemic, we already had major staff shortages, so we didn't go into the pandemic in a great place to start. Then as businesses reopen, for-profit companies are putting unbelievable pressure on providers related to wages. As Medicaid providers, we're not allowed to ask the people we support to help cover the cost of funding shortfalls. So what we can pay is very limited, and we absolutely cannot compete with Walmart, Amazon, Target, and Costco, and many other employers. Fatigue and burnout is very real. Every week there's a new article about mental health issues for people and staff on the front lines, and DD provider staff are a big part of that group. And when you add the fact that they're doing incredibly hard jobs under challenging circumstances and being paid less than what people earn to stock shelves, that is a recipe for staff shortages. Going beyond the workforce issues, another challenging factor is the need to be extremely rigorous in health and safety measures. That places a tremendous amount of pressure on providers and staff around making sure that we are doing everything possible to keep people as safe as possible. And that is really driven by what you heard Rachel speak about in terms of the incredibly high risk factors for people with intellectual and developmental disabilities. There is a lot of uncertainty for us regarding the pandemic. What happens over the next 6 to 12 months makes it very difficult to plan moving forward. And there's uncertainty regarding what supports and services will look like after the pandemic. And as Deputy Secretary Simons mentioned, there's an increasing reliance on remote and virtual supports. What people are going to want when they feel comfortable coming out of the pandemic. We talk about it about our own employees, and just everyone as people. What do people want when this is over? We've been in it so long that what people expect is very different, and what people who use supports in their families want and need, we know is changing and will change, but we don't know where that end place is going to be for us. And then the last significant challenge that I'll mention is the ongoing and concurrent major systems change for developmental disability supports. This committee has looked at this issue a lot. Deputy Secretary Simons and Deputy Secretary Hsu touched on it. We'll be transitioning to a new rate system, a new information and billing management system. Those two things are the most significant system changes that we could face as a provider community. So all of that creates a bit of a perfect storm for people with developmental disabilities and community providers. Providers are projecting they will see financial losses in the second half of this fiscal year as Appendix K flexibilities end. Having said that, I want to say we support the department's intent to use the ARPA funding, both for grants to providers and to help implement rate setting. That is really critical. And we are deeply appreciative of Secretary Schrader's commitment to addressing the workforce crisis. That is incredibly clear that he and his team really understand that without a workforce, we can't do what we do. Our biggest concern is the uncertainty of how all these issues will play out. DD providers are largely in a vulnerable position that will affect the people we support. And every step forward has to be done carefully, not only for providers, but with the Department of Health, the Developmental Disabilities Administration, and all of the systems changes that are happening. And we really have to have the utmost concern for the impact that it will have on the people that we support. And as Rachel said, we just want to publicly acknowledge the work of Secretary Schrader and his leadership team in working diligently to work with us collaboratively to address these issues. So this is more of a things are bad, but we are at the table in having, I think, very productive discussions, and hope that we come back saying we came out of this looking great. But time will tell. So thank you, and I'm happy to answer any questions.
Thank you. Do we have questions from the committee for either of these panelists, Rachel London or Laura Howell? I am not seeing any hands up. It's 2:54, so I'm just going to close with a thank you for the work you've been doing over the last year as well. And just, I know you just touched on workforce issues and that there is progress being made, but this committee is looking at, of course, long-term care services, child care, and in general, trying to address the workforce challenges. So I'll ask the same question to you that I asked of Allison earlier in terms of her knowledge of the workforce. Is the workforce for providers, would it be fair to say that it's disproportionately female and or disproportionately people of color? Like what are we looking at in terms of that workforce?
I can't give you the exact numbers right now. I can certainly get them for you from some of the national studies, but there's no question that our workforce is predominantly female. I would say female, older, and people of color. Absolutely.
The reason I'm asking is because our meeting last month, we discussed sort of the changes and the challenges we're seeing in the workforce and how, more jobs have been created for men and more women have left the workforce, and different pressures that women are facing in the workforce that maybe we want to address, from a policy perspective that may help take some of this pressure off and help with the more direct workforce challenges that you're feeling. So, to the extent that, I guess it's more of a comment than a question. I thought I pretty much understood that your workforce had a lot of commonalities with the other childcare workforce and with the nursing home workforce, and that we really need to figure out how to make sure to make to create a state where we can invest in that workforce. And if you have any interesting ideas or any anything coming from the ground up for things that we could do to make these jobs easier to support the workforce, let us know, because this is something we're really interested. Obviously, the problem's been demonstrated. So thank you.
Thank you.
All right, I don't see any more questions from the committee. So with that, we are meeting again in November. I wish I pulled up the exact date for you guys, but I did not. I'm going to guess it's the first week of November. You'll get an email. And that is going to be the meeting where we discuss early learning and childcare issues and learning loss, and sort of connect all of the dots from all the workforce stuff we've been talking about. And God bless her is telling us it's November 10th. So join us again on November 10th. And thank you very much to the committee for your time today. We really appreciate it. And all of our presenters, thanks so much. Have a good day. Bye. Oh, wait, Addie, do you have a question, Senator Eckert? Or are you just waving? Okay, good. Bye, everybody.